Hello, this is Todd Wills. I'm an assistant professor of infectious diseases at the University of South Florida, and today we'll be speaking about healthcare disparities, looking especially at the challenges we face in the developed world in responding to the challenges of the developing world. So we're going to look at this from a slightly different perspective. I don't know if any of you in the audience are aware, but a new president was elected and inaugurated last week. His name is Barack Obama, and as part of his inaugural address, he laid out a lot of new goals and initiatives for us as a nation. It's a rather somber speech because we face a lot of challenges both domestically and worldwide. And one of the things that he touched on were the challenges regarding global health care. And I'll just read a quote to you regarding that. He said, "To the people of poor nations, we pledge to work alongside you to make your farms flourish, to let clean waters flow, to nourish starved bodies and feed hungry minds. And to those nations like ours that enjoy relative plenty, we say we can no longer afford indifference to the suffering outside our borders." So, a bit of a call to action. The way that we can respond to these challenges, though, are rather controversial. And what I hope to look at tonight are the various ways that addressing healthcare disparity can go well and go wrong based on how we apply our best of intentions. And we'll look at ways that that has worked, ways that it doesn't work, and ways we might be able to address this in the future. Some of it calls for things that we can do domestically to actually improve the status of healthcare worldwide, and other things require some work on the ground in other countries. So here's our title slide again, just to remind us where we're looking tonight. We all live, again, in a land of relative plenty. We're moving into the Second Great Depression, but the degree of poverty that we face will still be markedly less than we see in most of the rest of the world. The per capita gross domestic product for the U.S. is somewhere around 30,000, and that's a benefit shared by relatively few countries nationwide. Many of the countries we're going to talk about have a per capita gross domestic product of around $500 or less. Luckier ones about $500 to $1,000 per person per year. Shopping for groceries last week, including diapers and other things, costs about $250 here in the U.S. right now. So imagine having to try to stretch that degree of resource over the course of a year. And that's what people face on a day-to-day basis. So the struggles that we face as far as whether we can afford a new iPhone or have to go with a non-3G component are very minimal compared to these challenges. These people are looking for access to clean water, access to food, and not all the time even able to attend to that in the most sanitary conditions. So it's a life and death struggle many times on a day-to-day basis. These are some of the water supplies you might see in a rural village in Africa. You can see these are soiled, they are contaminated. Fresh water, again, is one of the primary means of good health worldwide, and that's one of the first initiatives we try to stress whenever we're addressing global health. There's a lot of other things that we can do as well. But sometimes when we address a global healthcare concern, we start at the top and look at the newest and latest problem, rather than starting at the bottom and looking at what things can cause the greatest effect and the most benefit for the most people. And clean water is one of those interventions that can be quite beneficial to a lot of people. People face challenges on a day-to-day basis. Children in India, some of you may have seen or heard of Slumdog Millionaire, a study about a boy who overcomes his life in the slums of India to win Who Wants to Be a Millionaire, except the title Who Wants to Be a Millionaire is given in Indian. I haven't seen the movie, so I don't know how it ends, but I think he's probably happy at the end. It paints a somewhat bleak picture of living in the slums of India, but probably not as severe as people really do even experience on a day-to-day basis. Children that come from rural India going to the big city to try to make their way sometimes are kidnapped or taken into custody by a slum mafia who might mutilate them to gain extra profitability in their begging. So there's challenges that they face that are dramatic, and again, beyond that we even experience on a day-to-day basis. And I say that not because we're going to be able to go over personally and rescue people from mutilation, but because we need to have some perspective on the dramatic existence that people are facing there, so that we know when we're suggesting different changes or things that might occur, some of these might not even be possible or even make sense based on what they're facing on a day-to-day challenge. We're going to focus on a few things that are concepts that aren't always talked about in our public health discussions. A lot of these are ill effects of our best of intentions. What most of us want to do always as a first impulse to solve a problem is give money to it, or invest in that greatest emergency that we notice right now. We're going to look at how some of these emergent responses that we've done in the past have had ill consequences, and how we might restructure our approaches to help in the long term. The things we're going to look at first is a concept called brain drain, and we'll talk a little bit more about that as we move forward. And that's probably one of the most important things we're going to talk about tonight. And brain drain is just a concept that the developed world is slowly but rather efficiently draining the intellectual resources from most of the developing world. And it makes sense that this occurs. Most of the high-paying healthcare and technical jobs are in the developed world. And in any individual self-interest, it makes the most sense to move to that place where they can offer the greatest reimbursement. Many of you point to yourselves and say, we are people who have done that ourselves. And again, there's no reason that you shouldn't do that. That's where your rewards lie. But when a country invests to educate you, there is a loss of their own investment when those resources go elsewhere. We'll look at how that might affect things worldwide, as well as how we might respond to that. And it's not simply to keep you from coming here. It's to figure out ways to make it worthwhile to stay where you're at. At the end of this lecture, we will deport all the foreign fellows. Right. To Dr. Ayler's benefit, you all have come here. And for some of you, it is beneficial for me as well. And you can all introspectively look and figure out where you lie in that spectrum. Another issue that we face, and one that also has led to a imbalance of distribution of resources, is single disease funding. And that is where we target something like HIV, or we target tuberculosis and say, we need to invest in fighting this disease. And we fight this disease in countries and cities where 40 other diseases or 40 other problems exist that also cause as much morbidity and mortality as the one that we're investing in. Sometimes our resources aren't even allowed to address those other diseases because they're earmarked for one specific focus. We'll look at what we can do to correct that and where we've fallen awry because of doing that. Another important thing that might counteract some of the difficulties of brain drain is what I call sustainable local training. And that is one of the things that we can do on the developed world side. And that is to say, we have rather good estimates of what our physician needs, our nursing needs, our affiliated healthcare needs are on a country-by-country basis. But in the U.S., we never train enough MDs in our own medical schools to fill our physician needs. So there is obviously always a year-to-year requirement to import new doctors from other countries. So to fulfill our need for medical care, we take from other countries. And we do that far in excess of even any of the other developed countries. We in fact take physicians from developed countries because it's even better here than it is there. So we are the biggest vacuum of healthcare resources, and we can figure out a way to address that as well. And then on a slightly different tack, we're just going to look a little bit about international research. And the reason we look at that again is that is an area where developed countries are becoming more and more involved in on-the-ground care in developing countries, but we have to be especially careful so that the research we do has benefit for all sides. So this is a definition of brain drain. It's the loss of skilled intellectual and technical labor through the movement of labor to more favorable geographic, economic, or professional environments. So going where it's better. This is a map by the International Monetary Fund that looks at per capita GDP. And again, the blue countries are not, in fact, in this case, democratic voting countries. They may or may not be. They have the highest per capita GDP. Now, it's possible that if they vote Democratic, they could sustain their high GDP over time. The red states have a worse economy. And in this case, again, this is per capita, not a Republican voting preference. But if we if we look at this, if we look at the states with the lowest GDP, you can see that a preponderance of them are in sub-Saharan Africa and also in Central Asia. Now, remember those states, the ones in orange and red, when we look at the areas with the greatest shortage of healthcare workers. Again, they lie in the same areas. And it makes sense because those areas don't have enough financial resources to lure someone to stay. So people will always seek out training at a place where they have greater financial reward. We'll look a bit at the migration patterns of healthcare workers, and you'll see how they move progressively from the least developed more and more to developed areas until they end up, in many cases, here in the United States. Even in North and South America, there's a need for more healthcare workers, but again, they lie mostly in Central America and South America, not in Canada or the United States, which have most of the healthcare resources that they need. Again, if you look at Africa, they need 140% more healthcare workers than they currently have in order to fulfill their needs. And when we talk about the needs that they have, we're talking about United Nations Millennium Development Goals. So these are set down by the United Nations as what a nation should have as far as a number of doctors per unit population. Developed countries have met those. The less developed countries have a ways to go. Why do people leave? In many cases, it's obvious. The number one reason among surveys of 6 sub-Saharan countries that a physician will leave their country to train elsewhere or to work elsewhere is that they get paid better. Some will leave because they want to get better experience. They want to train in a more technically advanced society so that they can, in some cases, bring that training back. But unfortunately, in most cases, that training stays where it was received, and they then work in the more developed country. Living conditions can be poor. Lack of promotion is difficult, and this is something that we see in some of the less developed public health infrastructure systems worldwide. The ministries of health, the people who work to promote the doctors, aren't well trained or turn over frequently, and the doctors feel that they're lost in a system, so they leave that system as well. Some of them even complain of a heavy workload, and again, here when we see 20 to 30 patients in a day, we feel we've exhausted ourselves. 20 to 30 patients might be something seen in an hour or two in another country. So heavy workload is relative, but again, a reason you might leave what are otherwise less than favorable conditions. So all that being said, let's look at 4 countries that are thought to be the customers for healthcare workers. We're going to look at the United States, United Kingdom, Canada, and Australia. This is a chart from one of the articles that you have there looking at characteristics of international medical graduates and physician workforces in each of these countries. If you look at the number of physicians per 100,000 population, all of the countries have relatively similar numbers. The U.S. has the most with about 291 physicians per 100,000 population. 25% of the workforce here in the U.S. and comparable numbers in the other countries are made up of international medical graduates out of the, and that makes up 200,000 of our physician workforce here in the U.S. The preponderance of all of those come from lower income countries. In the U.S. about 60%, and the U.K. about 75% of their physicians come from lower income countries. More dramatically, if you look at the migration within these developed countries, you can even see that Canada, Australia take in a lot of physicians from other developed countries. many physicians will leave the UK to work in those other two countries. The US doesn't tend to take in a lot of others from the developed countries. Again, many of our physician needs are fulfilled by international medical graduates. What are we looking at here, Dr. Kelkar? Right, so these are the slums of Mumbai. This is a nation, India, with a per capita GDP of about $500 to $1,000 per person, and it's one of the sources in the U.S. of many of our international medical graduates. If you look here at the United States, international medical graduates and the country of origin, 5% of our international medical graduates come from India. And India, again, is not a country that has fulfilled all its medical needs, so it's shipping people elsewhere. They're coming here because there is a remuneration that they receive. There's a lot of U.S. international medical graduates. These would be offshore schools, etc. And then you see the Philippines, Pakistan, Iran. I've heard that we have some fellows from there. Right. Poland, Colombia, all of these places are sources of our physician workforce. And in addition to the physician workforce, in the background, remember that we do similar recruitments for our nursing workforce, maybe even more dramatically. So all of the healthcare workforce is being sucked in some way away. This is just a description of the problem. It's not a judgment call to say this is good or bad. It is simply what occurs. For people who have left their country and come to work for higher compensation, it is overall a better outcome, a way of life that we sort of describe as the optimum American dream, coming from elsewhere and making your way in the new country. Where do most of the physicians stay, and where do most of them leave? If we look here, the author of this article calculated what we would call an emigration factor. It's the likelihood that someone will leave the place where they trained as opposed to stay in the place where they trained. In sub-Saharan Africa, there's a 14-fold greater likelihood that you will leave the country of your training to work elsewhere, compared to in North America, where the likelihood is you're going to stay where you trained. If we look further at that sub-Saharan Africa data, you would find that people might leave a sub-Saharan African country, go first to South Africa, before then going to a slightly more developed country, and then possibly going to Britain, Canada, and eventually to the United States. So always a stepwise progression, looking for more sophisticated training and greater financial benefit. The World Health Organization has identified brain drain as one of the things that they're focusing on to address. How they will address it is what we're going to look at. And again, none of these ideas are fully tested. They're hypotheses of ways that we can hopefully stem this tide so that nations that invest a great deal in the training of their own citizens can hope to look to those citizens to provide health care for their population. The Millennial Development Goals estimate that we need about 2.5 healthcare workers for every 1,000 population. That doesn't necessarily need to be doctors. These could be nurses or others. So that's a general count. And just as a side note, one of the ways that potentially people have proposed to address this situation is to allow non-MDs to do more and more medical care. So allowing highly trained nurses to not only deliver babies, but in some settings perform cesarean sections, to provide most of the routine medical care, triaging people to a different location for the most sophisticated of care. It's a controversial thing, but again, one of those things that allows knowledge resources to stay in the country of origin. Based on these Millennial Development Goals, there's about 57 countries that have a critical shortage of healthcare workers. Most of them are in sub-Saharan Africa. And worldwide, the estimate would be that we need about 2.4 million more healthcare workers to fulfill this shortage. If we look at the number of healthcare workers in a region based on their relative global burden of disease. We can see again that based on the amount of disease in the developed world, the Americas and Europe, there is a shocking disproportionate amount of healthcare workers, where in Africa, Southeast Asia, and the Eastern Mediterranean, there is a minuscule amount of healthcare workers, while they make up the majority of disease burden worldwide. So we have a lot of people here to treat relatively little, not many people elsewhere to treat rampant disease. So how can we address that? Again, that's what we're talking about tonight. If you think about the healthcare workforce, one of the things that we talk about is the entire lifespan of their work, from when someone chooses to enter a profession to entering that profession and then becoming a sustainable worker in that profession. When we prepare the workforce, that's what we talk about when we say job training. Who and how are we going to educate people and recruit people for certain jobs? And in most of the countries that we're talking about, Sub-Saharan Africa, the Indian subcontinent, there is a relatively well-developed educational system. Medical schools are populated by knowledgeable faculty members. The students face a very competitive course to enter those medical schools and achieve their training. And many of them are doing this in populations much larger than we experience here. Many of you who came from other countries know how competitive it was for you to get into medical school. So that part is there. We are able to educate and recruit people. When we move into the workforce, this is where people then may become disenchanted with the work that they're doing. And they can be disenchanted because their supervisors don't attend to the needs that they have as a healthcare worker. Their compensation in many of these cases is far below that which they expect after the training that they've gone through. There aren't system support for them. So they may want to do a lot for the patients they're taking care of. The system that they work in doesn't allow them to do that. And so they're burned out by a loss of hope for what they can hope to give to their patients. And then in some cases there's a deficit of lifelong learning. Once they leave the confines of the medical school, they don't have access to learned people in their own discipline. They're so widespread that they can't talk about their education or advance their learning as much as they'd hoped to before. If we address those concerns of the workforce, we hope to have a high-performing workforce. So people that are happy in those parameters tend to be available, meaning they stay where they are and continue to work. They maintain their competence by continuing to be trained, and they're productive workers. If we fail in those, then we can lead to attrition of the workforce. People will either change their career choice completely, say, I could do much better selling cell phones rather than taking care of these patients. They may retire much earlier than we would hope they would, or they may migrate, and that's migration then leads to that brain drain to the developed world that we talk about. If we look again, this is similar details to what we had already talked about, but looking at the healthcare worker crisis in Africa, if we look at Africa's burden of disease worldwide, they make up about a quarter of serious diseases. They have about 1.3% of the workforce. So again, a significant disproportionate representation of healthcare workers there. What are we looking at here? It's hard to recognize without landmarks. So these are the slums of Soweto in South Africa, and again, abject poverty, lack of healthcare resources, and this is actually a nation where people trained in other countries of sub-Saharan Africa move to because it is more developed than they may have experienced. So again, this is not something we see when we go to the poorest areas of Tampa. There are not ramshackle slums one upon the next. The level of poverty here, remarkable, and something that we hope to never experience. But a significant reason why someone would say, why do I want to stay here when I might be able to go elsewhere? And if the rewards aren't there, there's every motivation to seek your own training fortune, better welfare for your family in yet another country. The World Health Organization looked at some of the causes of the healthcare worker crisis in Africa. Why are there only 1% of the physicians worldwide taking care of all of these patients? One problem is that we don't even know a lot about their healthcare workforce. Who really is trained, and in what regard are they trained? Are there people that might be able to provide more sophisticated services than they are allowed to? It's something that we don't know. People in the health professions are rarely recruited into the public sector. Most of the physicians in the developing world tend to work in a private practice environment if they work at all. So they are doing fee-for-service care for individuals who have the ability to pay. That leaves most of the impoverished citizens of those countries lacking access to those healthcare workers. So when we do a calculation to say the number of healthcare workers per unit population, even that is probably an underestimate, because many of those healthcare workers are taking care of a minority of the population with resources, leaving a relative few to take care of the masses. There's poor retention of workers in Africa. People are forced into early retirement. In many cases, they are afflicted with the same diseases we're hoping that they will treat. So many healthcare workers are dying of HIV and AIDS in the countries where we need more workers to address not only that, but infant mortality, etc. And tuberculosis is one of the common causes of death there as well. And then migration, as we had talked about, one of the other siphons of the healthcare workforce.
One comment I repeatedly hear and have read in Lancet is that no matter where you train, physicians are intrinsically curious, and I like intellectual stimulation.
Mm-hmm.
And when you're in the Horn of Africa,
right.
not only is there no internet, there's no telephone,
Right.
there's no medical journals,
Right.
there's no way to really grow intellectually.
Right.
People that have spent time in third world environments and want to comment, what was it like in Sudan? And it's just hard to find information.
Right.
People get very disgruntled with that, and they want to go where they can keep learning.
Right.
And just to add to what Todd was saying, is that there's a big urban-rural divide. If you see that in most of the developing countries, there's a large chunk of population in the rural areas. And there might be great systems on paper, like India probably has one of the best healthcare systems on paper. But they can't just implement it, because and John has raised a very important issue. Is if you go to many of these rural areas and you see the primary healthcare sector, the support services are miserable. There's no drugs, there's no intellectual stimulation. It's one doctor. He doesn't even have a good place that he can live in. So even though you have this intellectual group that is really well trained and wants to, even if they want to provide services, there are no opportunities for them to provide those services. So unless there's a whole change in this culture and the system of providing care, it's going to be hard for those doctors to stay there.
Right. And that's one of the things the World Health Organization has at least identified as a potential area to address, is that some healthcare workers do want to stay where they're at, but they're so off the grid, outside of any network of colleagues, that they leave because of that alone. And that's where they actually encourage more involvement of the developed world, more collaborations with local hospitals on the ground, so that people have an intellectual outlet beyond just their own textbooks that they brought from school, living in a village on their own. We've talked a lot about where people go, how they migrate from their initial training elsewhere. And this is looking at migration patterns in Africa, where physicians go progressively. If you look at the... Oh, this has a laser pointer. Fantastic. If you look at here, this is other African countries. The center of the graph is South Africa, either rural or urban areas. There is migration within Africa to South Africa. Not a lot of migration in the other way. Again, we're going from the least developed to a slightly more developed outpost. And then from South Africa, people will go to any number of developed countries. Canada, the US, UK, Australia, New Zealand. Some from Cuba will even go to South Africa for further training. Once people get to the developed countries, you can see that people from the UK might go to Canada, people from the UK might go to the US, some from Canada might go to the US, none of the arrows from the U.S. go elsewhere. So that's where people stay. This is where the greatest rewards right now for a physician come, as far as at least financial compensation, and in some cases intellectual reward, a collegial atmosphere, etc. This didn't reproduce very well, but it's also in one of your articles. When developed countries talk about their own export of physicians, those numbers also tend to lead us astray. This polygon looks at migration and export of physicians of these four most developed countries: the UK, Australia, the US, and Canada. And as you can see, most of the export of physicians in these four places is to one of the other four places. So we're not training physicians that go to India or go to Africa in large part to provide services. We're training physicians that might decide they want to go work in Canada. So we're not really addressing a new healthcare need. We're just moving laterally. In addition to some of those migration problems that we talked about, there's a lot more things that are identified as far as public health infrastructure in India, sub-Saharan Africa. One of them is that the human resource units in the ministries of health tend to be very weak. There's no one that advocates for improved working conditions among the healthcare workers. Many of these ministries will change completely as a government changes from one administration to the next. So there's not people who are set in place as long-term staffers that improve those working conditions from one generation to the next. The personnel functions don't have the support that they need policy-wise. So if someone does have a good idea how they might remunerate their physicians, reward them more, develop greater internet learning or video conferencing capabilities, there's no support for that at the larger government level. Again, if you think of a populist-based political approach, here in the US, even if you were running for office and said, I think we need to give more resources to the doctors, it wouldn't be considered to be an at-need population. And the same would be true in a developing country. The doctors are still at the highest end of the economic ladder there, and so they aren't seen as an area that needs most financial resources taken toward them. But because of that approach, there are significant deficits in the healthcare that can be provided. One of the things that also causes a problem is that of all the different funding resources that work to address these problems, non-governmental organizations, government funding from the U.S., charitable organizations like the Red Cross, there isn't always integration of their work. So we may decide we need to address infant mortality, and 4 different organizations decide to address that. They don't do that by having 4 times the resources address a single question. They address that question 4 times in slightly different ways, sometimes competing amongst themselves. So we haven't used the resources from the developed world in the best way to address some of the financial needs or structural needs of the other countries. Other things that we need to do, one is to align pre-service education with some of the healthcare priorities. And this is what I talked about earlier. One of the potential ways to fill some of the deficits of healthcare workers may be to change the definitions of what a healthcare worker is or what someone at a certain level of training may provide. So that may be creating super nurses or people more practicing like a nurse practitioner in many of the developed countries. You don't need a doctor in the rural health center at all times, but you have someone who's well trained at a specific skill. If you have a rural population where they deliver 80 babies a day, that person who may be not trained at a medical school may be very competent delivering babies and could be trained specifically in cesarean sections or other things as long as backup was provided. So we can spread those resources out, especially among people that might have a greater motivation to stay in the country that they are. Some of those degrees or job titles might not even be transferable to another country. So you can make a good job in your own home country, but you might not be able to move to the U.S. and be a super nurse, but you can do that very well in your own home environment. one of the more important things, and that's what I bold at the bottom, is sustainability-focused solutions. Does anyone have an idea what that might mean? So if we were talking about paper, it would be that we are talking about recyclable resources. We would say that paper is a sustainable resource because we can grow another tree and have more paper. We talk about this in healthcare workers, the same is true. If we create enough educational opportunities in developed countries, we can sustain our need by educating our own. And that's what some of the priorities have changed to for developed countries. We'll talk a little bit more about this later.
What also happens, and there's actually been a lot of discussion about immigration in the United States.
Mm-hmm.
And in one opinion piece, it was said that America would be a desirable place to relocate to for the next 20 years. After that, it's really unclear because other nations come up to our standard of living.
Right.
And they actually advocate recruiting MDs and PhDs from other countries and accentuating the brain drain to ensure America's primacy. So it actually serves a political end as well. And this is a discussion within part of the Senate.
Right. I don't think there would be any question that the more highly trained individuals here in the U.S., the better it is for the U.S. But the outcome for the other countries could remain in question. We talked.
But it really would save money on education.
Right. It's
Nutrition.
cheaper here to have people work hard and train elsewhere, and just pay them when they're done. But it might not be overall always the best strategy.
No, I mean that.
Right.
I'm saying that there are ideas even.
Right.
But that is a discussion taking place about immigration policy now. Because now, as I understand it, they'll selectively take relatives. So you're
Right.
cab drivers, you can bring your immediate family. Well, that may be changing. So instead of 40 cab drivers from Haiti, well, they're going to take 40 doctors.
Right.
In which case, Port-au-Prince would have 0 doctors.
Right. Well, even in the latest immigration debate, of all the different pathways where visa options were decreased, J-1 visas for healthcare workers were increased. So there's not a immigration strategy on the U.S. side that says we're going to address this by limiting the amount of people we'll bring in. There's a recognition that we still need a lot more doctors. Let's bring in as many as we can. We talked a little bit about single disease funding earlier and some of the problems that arise from that. Single disease funding in general just means that there's a large motivation to devote resources to some disease state. The best example of that is funding for HIV/AIDS. 2005, the President's Emergency Fund plan for AIDS relief donated about $15 billion for AIDS funding, and that was the largest amount worldwide of any of the developed countries. But again, a disease-focused funding.
2008,
Right.
Part 2,
Yeah.
30 billion.
Right, and these numbers continue to go up. They are definitely addressing a need. There is no question that HIV/AIDS has had vast and detrimental consequences to the countries where the funds are targeting. What is problematic about single disease funding is that it also often comes with significant strings, be they how you can use the funds, who can use the funds, what they can say to people when they use the funds, and all of these can significantly limit the impact that's had. They also tend to come in waves, so there's vast excitement about a single problem. That single problem is addressed or controlled, and then people don't worry about it anymore, where the public health infrastructure, the medical infrastructure of that nation is not significantly different than it was before all that many came and went. And we see the same with the Asian tsunami, a big upswell of relief that came and went, even with avian influenza, large donations to countries in Asia in 2006 because of fears for our own public health. And again, that money comes and goes. In some cases, it's good. Some of this money goes toward improving laboratory infrastructure, training new physicians, improving hospital facilities. And so, although it's focusing on a single disease entity, the use of the funds can actually cross across many things. But in most situations, the money targets something that is specific only to that and leaves other things unaddressed. Nutritional problems, diarrheal problems among infants, infant mortality, all of that may or may not be addressed by a single disease focus. Yes.
And it's very interesting. There is a social scientist who has done an analysis to show how multi-drug resistance has become an issue now with tuberculosis because they had stopped funding for TB in many parts of the world in the 80s because the US was doing so well. They didn't have a huge problem with TB, so there was a big focus on family planning worldwide. So all of the money for primary healthcare went into family planning, and TB is generally considered one of the diseases in India where you're supposed to have a lot of funding, and they reduced the funding for that. And as a result, they've seen that there was this whole, there were drugs not available. Of course, other than the other issues that are there because of multi-drug resistance, but it has been shown that multi-drug resistance had started in some parts of the world, like in India, pretty early on, but nobody focused on it, and it's become a major issue now.
Right.
So,
And that's exactly the sort of patterns you can see. We even see it in the U.S. to some degree. I think if you've seen Dr. Tony's talks about STD funding, STDs have become more prevalent and more incident diseases because funding for STD prevention and training has dropped. So there's always a link of where funding goes. If you're not addressing the entire healthcare system and it's just simply looking at one problem to the next, shifts can always occur. Now, it can always be answered if we had unlimited resources, but we don't, so there's still tough decisions that we have to make. When you look at advantages and disadvantages of focusing on a single disease state, one advantage is that, especially in the category of infrastructure development, the funds still benefit everyone. The hospitals are improved, the clinics are improved. That will be the case whether you're coming in with a pneumonia, AIDS, cancer, etc. If international resources go to focus on a single disease entity, some of the local resources can then address those other priorities. So instead of spending all your money in Africa on AIDS funding, some of that funding is coming from elsewhere, and you may be able to use your funding to address those other priorities. So again, that would always be an advantage if that's how the resources shift. And even the government can focus on other priorities as well. So they may need economic development completely outside of the healthcare arena, and it may allow that to occur. Disadvantages of single funding. One of the primary is that the funds come with strict provisions for use. You wouldn't be able to spend HIV/AIDS money necessarily on improving a breastfeeding program for mothers or providing formula for people who are malnourished unless it fell strictly under the proviso of an AIDS diagnosis. Even in the U.S., again, we hear anecdotes of people that will seek to be infected with HIV because then they can access the healthcare system. And you can see similar motivations either among patients or among practitioners to go to that area where the money is. Someone who may have a significant interest in taking care of emerging malignancy in a country will instead become an HIV/AIDS specialist because those doctors are getting paid twice as much as anyone else, and their salaries are being topped off. So there's almost an internal brain drain that occurs when you have single disease focus. People will all go to the disease where the money is being spent, thereby sacrificing some of those others that still are urgent needs. There's also diversion of funds. Anytime you have a big influx of monies, it doesn't all go where it needs to. People who are writing grants for the funds might create new employees for jobs that don't exist. They'll siphon up some of those monies. Some may be taken by people with criminal intents. So only about 50% or less of funds that are meant to go for a single disease state end up where they're supposed to go. And we had already talked about the lack of coordination of donor activities. And again, when multiple agencies are focusing on the same disease state, those efforts aren't always coordinated and may duplicate each other rather than causing an additive effect. one concept that you'll see from the World Health Organization is a concept of stovepiping, and that's where I think Abraham Lincoln wore a stovepipe hat. So if you wanted to get money onto his head, you'd open the top of the hat and put it down. And it's the same thing that would occur here with worldwide healthcare funding. You just have a pipe that goes to that single disease entity. On the ground, people aren't able to prioritize where those funds might be better used to improve healthcare for more and more people. And then that local brain drain concept that we talked about. Again, healthcare workers will seek internally those jobs that pay the most. So what can developed nations do to try to address some of these issues that we've talked about? One of the concepts is to try to achieve self-sufficiency and sustainability in making our own healthcare workforce. What are ways we can do that? Well, as you saw at the beginning, about 25% of our physicians are international medical graduates. And we know that's the need to fulfill the healthcare needs that we have right now. If we increased student enrollment in our own medical schools and nursing schools, that would at least partially address some of these deficits. We need to reduce student attrition, and part of this even may be that compensation for physicians or work environment for physicians also isn't as desirable as it might be in developed countries. Before our depression started, many people would see, many people would rather seek a job in financial services or financial sectors rather than a job in medicine because compensation came much better, possibly sometimes with even a lesser workload. So those are things we have to address as well. And we also want to do things to enhance our healthcare worker productivity so that the doctors, nurses that we have here are working more effectively, providing more services to a greater number of people. Yeah. Right. It is there's a motivation to go to the jobs that although they say that although healthcare work is supposed to be a recession and depression resistant field, it still isn't to all degrees, especially if you're working in like plastic surgery or cosmetic dentistry or something like that. Yeah.
Fallacy. And let me use just the example of Tampa General. Okay? About 20% of Tampa General's income is actually income from investments. It's not income from patient care.
Right.
They have money for a rainy day put aside, $40 million that they invest. Well, that was, instead of getting, say, 12%, with that amount of money
And so all of this is a good point as to how the previous administration actually addressed a lot of the problems with brain drain by causing such an economic crisis that there's less motivation to even come here anymore. So some of our answers are already provided. Right. They said they said, I see a need globally that we can address. Other things that could be options for achieving at least sustainable healthcare worker supplies here in the U.S. One would be to slowly roll back visas for healthcare workers as we simultaneously up-ramp our training slots for nurses and physicians. That's always a controversial thing. Again, it's taking away some of those opportunities for people to seek better employment elsewhere. And it should only be done simultaneously with efforts on the ground in home countries to improve the work environment, improve the reasons that people would stay in their own home country. A lot of this will require a significant increase in student enrollment in U.S. medical and nursing schools. We always talk about the nursing shortage in the U.S. and that we have to go to the Philippines, Vietnam, elsewhere to recruit nurses here. One of the initial notions would be that it must be that anyone who wants to be a nurse here is allowed into school, and then we're seeking out the extra people. But no, we reject about 150,000 people that want to be nurses here. And many of those are qualified applicants. It's not that these are people that are failing applicants. It's simply that we have a limitation on the number of slots we provide. Among the ways that we could increase even more qualified applicants is to improve, again, working conditions for nurses. It is not considered among many people to be one of the most desirable professions to go in, so it's capturing less of the best and brightest of students who could seek a nursing career. And both of those things are things that could be done to improve that deficit. And then something that would be favorable for all of this is to improve the compensation of healthcare workers to attract even more trainees. And that might be a challenge in the current financial situation. Yes. Right. Well, a large proportion of our international medical graduates, if they're recruited to work here, are working in primary care because they have visa benefits that derive from that. Right, and then they may go elsewhere. One of the things, and we'll talk a little bit about this more with what the American Association of Medical Colleges has proposed. One of their largest proposals is that we need to do more to attract our own domestic graduates to work in rural settings through probably more aggressive loan forgiveness programs, greater support for compensation, etc. So that's yet another secondary problem in the developed countries, is people will again seek out that highest level of compensation.
Again, they boil it down to financial issue.
Right.
But it's also not. It often is, though.
Well, it is.
Right.
Right.
Tomorrow and said, I'll pay you $20,000 a year more to work.
Mm-hmm.
You wouldn't have to move your house, and you probably wouldn't do it. I hope. Okay.
It's $20,000 more. I mean, based on all the motivations we saw here, I would go immediately. $300 more, I'd probably stay. Right. Right.
There's no glamour in the profession, and then
Right.
professors are not inspiring their students to think of primary care as an option.
No, I think it's because when you graduate on the day of graduating med school and you get that bill, you are like, holy smack, how fast can I make this money so I don't have this on top of my head?
Right.
I'm trying to get married, trying to have kids, trying to buy a house, trying to do this, X, Y, Z.
But if that were
To have
if that were exclusively the case, no one would go into our specialty either, because our compensation is actually on average less than it would be if you had gone into internal medicine 2 years ago. So there is some benefit you get from practicing or doing something intellectually that you want to do. So right, but that's why things like loan forgiveness for going into a certain specialty may be more beneficial than not. If someone has a calling to serve a primary care need and they're only not going into that calling because they need to pay off monies, I would be surprised by that, because it's again, it's the same as when you talk about someone applying to medical school. We say you should really want to be a doctor to go to medical school. You shouldn't go there because you want to make money. The same is probably true about deciding to be a family practitioner or a plastic surgeon. If you decided to be a plastic surgeon only because you wanted to make money, but really wanted to be a family practitioner, you can probably figure out ways to pay your debt and be a family practitioner rather than going into a career you don't want.
I mean, I'll just take the stats in my class. About 110 students, only 3 people went into primary care. One was in the VA, one worked in his father's office, and one at US Staff.
Right.
And nobody took the AHEC option, which is the loan forgiveness for 3 years in an underserved.
Right. But part of it could be, as Lynette said, it might be a failure on our part as educators to make primary care seem like an option that you would want to do. Right. And in many cases, a highly functional primary care practitioner has an astounding responsibility and does amazing things. But if we discount what we expect of them, then no one will say, I want to go do that specialty that people think doesn't do anything.
And if you're really honest about it, I
Right.
mean, if you go around in the medical field, who wants, we don't really look very highly if somebody says that they're a family medicine or, or doing primary care work as we
Right.
do when it's a specialist. It is how our society is. It is
Right.
how we have conditioned, people to think. So
I don't think that's true. I don't think that's true. I think it may be true. It may be true in an academic center, but it's not true in a community.
even in the community.
I don't think that's true in the community.
Todd, how many family practitioners on staff at Tampa General?
You mean Jose? Or would you like me to try?
How many at St. Joe's?
I know one.
No, Maurice Bonilla is board certified in internal
Internal
medicine.
medicine. But he's a generalist. He has an
I
office
mean, I know
practice.
the Plant City doctor I shadowed when I was in med school, he used to still run inpatient, but that's at Plant City. He also still delivers. Part of this is a Florida issue that I remember being
to our audience in outer space. We were taking a brief break to discuss some of the intricacies of healthcare provision in the state of Florida. We'll now return to our international setting.
Can you say this in Jupiterian, please? The outer space audience.
I cannot speak in outer space languages right now. See, you've reminded me of a song I was almost going to start singing, but yeah.
Dr. Tony has the universal translator app on his iPhone.
Oh, that's good. Well, I'll have to speak about it anyway. We've had enough of a break. If any of you know of the artist Chameleonaire, raise your hands if you do. Dr. Sinnott, what was his popular song?
I don't know his popular song, I just know he's a singer.
Right. He was known for the song Ridin' Dirty, which was parodied by parody artist Weird Al Yankovic, who is well known among Caucasians. And his artistic tour de force was White and Nerdy. And speaking of foreign languages, one of his lyrics was that he was fluent in JavaScript as well as Klingon. So, and now we return to the lecture at hand, which is another lyric from a rap song, but if any of you are aware, that's from The Chronic by Snoop Dogg and Dr. Dre. Snoop Dogg will be coming down actually as part of the Bud Bowl festivities at Channelside, along with 3 Doors Down. Tickets are free, but you do require a ticket for admission. Super Bowl 43, Tampa Bay. So we've talked a little bit about the pros of a sustainable healthcare worker and some of the challenges we face. These are some of the disadvantages that that same approach might have. And for many of you here, one of those would be you'd have a reduced opportunity for employment here in the U.S. at all if we decrease the number of visas that we offered for that. There'd be limited professional growth in international care. Those of you who wanted to learn more at a more advanced healthcare setting might not be given that opportunity. We might have a reduction of brain gain, and that's what Dr. Sinnott was talking about. It is to the advantage of a country to have the best and brightest from elsewhere come and practice and work in that environment. And without that gain, those intellectual resources are elsewhere and can lead to competitive advantages in other countries around the world. And again, what's very important, we lose the ability to have a diverse healthcare workforce that can provide culturally relevant care to people in the U.S. We might not have a Vietnamese physician who can address the needs of a Vietnamese community, etc. We'll have a lot of people that might not be able to address that specifically. This is what the AAMC came out with as far as their policies regarding the physician workforce. And this is the American Association of Medical Colleges. What they identified as a problem is that in the 80s and 90s, most public policymakers and medical school deans identified the likelihood of a substantial physician excess by the time we got to the early 21st century. So enrollment in medical schools was flat. We didn't increase the size of classes because we wanted to do everything we could to not have too many physicians competing for too few resources. And when they look back, they think a lot of this was related to a miscalculation of the effect of managed care. It was thought that if managed care took hold in the model as it was proposed, there would be a lot more primary care physicians providing significant care with a decreased need for specialists. And we've seen probably the exact opposite occur with how primary care is being offered. Now by 2000 we found that significant shortages are actually what we've found in the physician workforce. Yes, Dr. Tony. Yeah, to have people both pursue their own academic interests, but also do more of
Yeah,
the
so that they could do
right,
a little more than just doing only
right.
academics.
And I think in very small pockets, there's attempts to have dual residencies, but the except for pulmonary critical care, I've also heard of ID critical care. I think there's a program that does that somewhere. Um, what's that? And NIH does that. But as far as actually a combined primary care plus specialty, um, I think the assumption is all the people who are trained in a specialty have that primary care training, but there's no model by which they actually are planning to employ the primary care component of it.
Even then, after family practice, there's only really two main fellowships I can remember offhand. There's the academic fellowship, and then there's the sports fellowship. And they compete with the ER slots. ER and family practice compete for the same sports fellowship.
What I'm happy about is that we are spending significant time addressing our domestic healthcare resources, while still facing a global crisis that we are not courageous enough to address, apparently. The other things AAMC recommended is that medical school enrollment probably needs to be increased by about 30% with a simultaneously increase in residency and fellowship slots. So we will fulfill more training slots domestically to make up for that need to recruit others from elsewhere. And another important thing that they recommend, and this talks about some of that, the perception and reality that physicians in rural settings internationally are left outside on their own. They don't have the ability to network or have intellectual discussions with others. That the AAMC is supporting more and more collaborations with med schools in the U.S., with hospitals, clinics, and med schools in less developed countries. So there is actually a way that people can have that intellectual exchange without being off the soil in their home country. And that's something that we've started here with our own programs, more and more intellectual exchanges with other universities. And that's going to be a trend that I think you'll see expand more and more. Other things that we can do also address some of those concepts of single donor focus. One of the best ways to use these limited resources effectively is to have more regulation of the funds on the ground. So when we give billions of dollars to another country, we have to see, is it really being used to address those needs that it was destined to meet? So that might be stamping out corruption, doing things that are very difficult. And these aren't easy things to answer. When the World Bank gives development monies, a lot of it goes by the wayside because of corruption and other problems. But it is probably one of the most important things so that the financial resources that are being invested go to the right place. We probably need to have less disease-specific funding. It might be more beneficial to say we want to address healthcare in the developing world, and we're going to make our resources focus on that. If we do that, the endpoints we measure in these countries have to be broader as well. Instead of seeing how many people are on antiretrovirals, we might simply be measuring changes in life expectancy or infant mortality, other things that demand an intact healthcare infrastructure across a wide range of markers. One thing that is a little more entrepreneurial is we might also invest some of our money in private sector healthcare industries, laboratory industries, pharmaceutical industries in developed countries, so that some of the novel developments take place on the ground elsewhere. We're not always importing pharmaceuticals from the developed world, but some of the brain capacity is being used to develop a healthcare industry on the ground. And we probably need to reduce some of the restrictions of use of funds for other countries. One of the big points of debate with some of the HIV/AIDS funding of previous administrations was that there were limitations on things as simple as advocating condom use, with always advocating first an abstinence-only approach. And some measures said that a approach advocating the use of condoms to prevent STD and HIV transmission was probably more effective. So we may have been actually halting some of the efficacy of our efforts by linking them to cultural values, held across the ocean. And those are
Just signed that.
right, and Obama reversed that recently. And right. But all of these are things we need to think about when we're committing significant resources to another country. We want to say, how can that money be used best? Otherwise, people will say, we gave that much money before and there wasn't a good outcome. Let's not give any more. Instead, if we think about how we're going to use it up front, we might see that growth and improvement that will encourage more and more countries to donate and continue that ongoing improvement. Richard, you had a comment? No, you didn't. Okay.
I can comment.
Yes, anything you'd like to say. Experience from Huntsville,
No, it just it occurred
space camp.
It's a great place, by the way.
Yeah.
It occurred to me that perhaps part of our initiative is to help other countries improve their programs, because the original, well, as I understand it, originally many foreign medical graduates, there was more parity, and so a great many more opted to return to their countries and share their knowledge and improve their healthcare systems. Not everyone, but that was
Right.
the case. So, I think people will always come to the U.S. when we need them. I think it's obviously it's our benefit. We benefit from the brain drain, so to speak. But if there was more parity, if we could figure out a way how to help other countries do that, perhaps more foreign medical graduates would have a reason to come back to their country as
Right.
well as choosing the option of staying here.
Yeah. And in other industries that's happened. I know even in like the IT industry, there are people in India that return to India to work there because they do get the same rewards, etc., that they might otherwise. Right. And yeah, because they're going back to meet their outsourced jobs. But there could be models where it may occur, but the challenge is there's such a significant difference in GDP and per capita income that it will nearly be impossible to match those rewards someone could have in another country. Here are some babies in a nursery in India. Again, much different than what we would see here. So a neonatologist practicing in India may have a great motivation to go elsewhere to have the access to those resources to help the babies that they're taking care of. This is a woman with, can you make a diagnosis here? What is it? She could have cholera.
Is that a cholera? Is there a bucket?
Could be. She could have chest pain.
Beds are usually canvas, they can clean.
Right. She could have HIV/AIDS. Does she look sick? Yeah. So she looks sick, so she's probably not doing very well. So we need to address whatever her problem is. Doesn't matter what it is, but we need to give resources that can help them to diagnose and improve her life expectancy. These are some of the condom education programs that were successful in India that, again, would be limited if we had very stringent criteria on our use of funding. What you see up on the upper side, these are some people going out to train and teach truck drivers who often have sex with commercial sex workers at truck stops in India as they're going across the country and travel. And if you had a program where this was a vital component and you had limitations on the use of condom education programs, that might not be a program that can then thrive. So those are some of the funding challenges that we talk about, and we've had a lot of discussion there. Our time is running late, so I'm going to run through the next component rather quickly. I think we've talked about some of this before. But the other place where the developed world plays a significant role in the developing world is in biomedical research. And this is another challenging area. Again, because most of the disease burden exists elsewhere, it is advantageous for developed countries to do biomedical research in developing countries. You can recruit patients faster, you have sicker patients, you can see endpoints much quicker, and then bring those drugs or tests or models to market. The problem is, when we do that, we're not always doing it with the benefit of the study population at hand. We might be trying to develop a drug only for use in the developed world and exposing a small amount of the developing world population to it just to get an answer. One of the things we have to do when doing international research is try to reconcile some of those cross-cultural values and ethics. We need to do things that are valuable for the culture where we're doing the research and for the patient population where the research is being studied. One concept we talk about is the economic disparity, where again 10% of the economic resources lie in these countries. 90% of the patients with the disease burden we're looking for might be in the same place. We have problems with informed consent. When we do an informed consent here, we know the language the patient's speaking in, we can assess their level of understanding. Are we always able to do that in another country? We may or may not be able to. So when we conduct research in another setting, we need to be a lot more sensitive to how we're communicating with people and whether they really are consenting in a knowledgeable way to the research that's being undertaken. And then another thing that's important internationally is to make sure that whatever you're studying is of benefit to the study population at hand, and that you plan to provide them post-study care. So if you're developing a new protease inhibitor, you go to sub-Saharan Africa, find that it works and has a good virologic control, you want to commit to providing that same level of care to people after the study is finished. You're not going to treat them for 48 weeks and then leave. And that does, again, create then some cost for doing research internationally. You are committing to elevate the level of care to the research subjects at hand. Placebo-controlled trials are one of the more controversial areas in international studies. And when we talk about placebo-controlled studies, we rarely see them in the US because we have standards of care to which new treatments are always being compared. Many people would debate that in the developing world, the standard of care is no care, so anything you might be able to introduce would be an improvement. And so placebos may still play a valuable role. That largely is discredited and is not advocated by any of the World Health agencies, but it is an area where there is much debate because access to care, access to treatments is quite limited. One of the best cases of the use of placebo-controlled trials probably comes from the ACTG protocol 076. And this is one of the more famous protocols of the AIDS clinical trials group. It's the one that determined that AZT given before delivery led to a decrease in vertical transmission of HIV. Before that study, we had no evidence that drug treatment could decrease mother-to-child transmission, and it does so quite effectively, reducing it in the AZT trials from 24% down to 8%, and subsequently with greater and greater advances, we've decreased that down to less than 1%. This study was a placebo-controlled trial when it was first done because we didn't know anything that worked. So we were seeing, does AZT give us a benefit or a harm, and what is the magnitude of that? Once that protocol came out, it was disseminated widely. But if you notice where the trial was first conducted, it was in the USA and France, where we had significant access to this. This was a very long protocol. It demanded multiple weeks on AZT prior to delivery. It established a new standard of care for pregnant women, and most industrialized countries adopted it. Developing countries didn't because they didn't have the resources to give that much AZT for that long. So what they looked up in follow-up studies, 17,000 women were enrolled in different trials, multiple different sites, and they were primarily looking at shorter courses of AZT therapy. Can we treat people less long, or were different regimens? And all of these were done in a placebo-controlled way. So you either received a short course of therapy or none at all. And most of them did show some benefit to a lesser degree, but they were again exposing half of their study arms to no therapy at all, when we already knew that therapy of some duration was beneficial. So that's where some of our initial controversy as far as the lack of placebo, of the inclusion of placebo-controlled trials came from. Advocates of placebo-controlled trials will say, in most of the countries that we're looking at them, a placebo is the standard of care, because we're looking at nothing versus something. The only other option people have is to just continue suffering from the disease we're studying. So it's really not a true choice. If we're offering them anything at all, we're giving them more than they could have. And a lot of people want to always have a placebo arm so they can account for any adverse reactions and definitely take them away from the baseline. And for AZT studies, you might see differential degrees of anemia, etc. The disadvantages of placebo-controlled trials, though, are as we have already discussed. You're exposing people to an arm of a study for which you already know there's a proven medically beneficial therapy. So the World Health Organization discourages any placebo-controlled trials except in situations where there is no known therapy. So that makes conducting research in international settings, again, more expensive. You may be doing research where your control arm itself is leagues beyond the standard of care of what is usually provided, and then your test arm is much more beyond that. And so it doesn't really resemble anything like what people might be having in their day-to-day clinical care. And if there's such a disparity between real-world studies and your study, that's probably not the population where you want to study, because whatever answer you get is not going to be of any benefit to the population at hand. You want to compare things that are realistically available to the population you're studying so that the answers are also applicable to them as well. And just one thing to finish up, some of the things we face also internationally are related to gender concerns. There are oftentimes significant differences in the power relationship of women to men in developing countries. When we're providing clinical care or research to individuals, those gender concerns can play a role. Some of the ways that they evolve, it may be because of education differences. Women might not be offered any opportunity for education, so for their medical care they need to rely on their spouse to explain their care, again through whatever bias or filter that they have. They have much less opportunity to seek education for higher learning like medical training, and they may not understand a consent process at all if you wanted to enroll them in research. Many times women face a lot less autonomy. They're not able to make decisions without the consent of their husband or father, or in rural settings a tribal leader, etc. So we can't always rely on them to be able to provide informed consent, and they may be blamed for medical diseases or other things where they don't have the power to disagree or confront a spouse. Women are much more likely to face stigma from medical diseases, and it's especially true when we're talking about things like HIV and AIDS. If you think about how women are more likely to be diagnosed, or how anyone is diagnosed in a developing country, there's a great likelihood that the first diagnosis of HIV in a couple will come from a woman when she's going for prenatal care. Although the likelihood is that she acquired that infection from her spouse, because relationships outside of the marriage are much more common for the men than the women, it is also more likely that she'll be blamed for the infection, because she was the first one to receive the diagnosis. She'll receive the stigma of the diagnosis. She'll be excluded from the family. She'll lose access to any financial resources. She'll lose access to her children because of that particular social structure. That can lead to people refusing testing, not seeking out health care, because they'd rather not know than face some of those repercussions. Again, women face those risks because of that. They can lose financial support or not be able to seek medical care because of a lack of financial support, and they still share the burden primarily for child care. So they may never seek health care because they always need to be home taking care of children, whereas men may have some greater access to that and greater access to finances to pay for some of the medicines that they need. So all of these are the things that we face when we try to address healthcare disparities worldwide and create our own priorities as a nation as to how to do it. And we'll finish with a quote from Gandhi, who right now, for his personal history, is probably even held in higher regard than Barack Obama, but we'll have to see what happens over the next 4 to 8 years. Gandhi said, "There's enough money in the world to satisfy the needs of everybody, but not enough to satisfy the greed of few." So again, we need to focus our approaches to distribute what are rather limited worldwide resources for the good of as many as possible. And that's all I have. I'll take any other questions you have.